and he's going to talk about something that has no controversy associated with it, and that is thoracolumbar burst fractures.
No, absolutely none. Thank you very much, Dr. Chapman, Dr. Scudian, for inviting me out here to a master's course. At this stage of my career, I certainly don't feel like a master, but I'm really honored to be presenting along with such giants, both literally and figuratively in our field. The subject of my talk today will be thoracolumbar burst fractures. I don't really have any relevant disclosures, and I recognize I have a 15-minute talk and I'm standing between everyone and freedom, so I will try to keep it short. But it's sort of difficult to talk about burst fractures, even in 2024, because I think this is one of those areas of medicine or surgery where we have true equipoise. By that I mean at an individual level. I think we all see burst fractures. I all think we have our own algorithms, our own preferences. Someone comes to the ER, we treat them, we take care of them, we move on without a lot of hemming and hawing. But what always strikes me about burst fractures, particularly thoracolumbar burst fractures, is that what is an obvious operative fracture to me may be non-operative in someone else's hands or views. What is obviously a posterior short segment approach in my hands may be a long segment or an anterior fusion in another's. And I think part of this problem, as alluded to by Dr. Failing's talk, is trauma is not one disease but many. And burst fractures, in particularly, refer to a mechanism of injury which encompasses a wide variety of fracture morphologies. And I think even in 2024, we have some definite challenges in classification of the fractures. The old Denis model, the 3-column model, I think has been outdated. I think it classified burst fractures by virtue of the middle column involvement as unstable injuries, and far too many people were operated on. And I think the gold standard these days is the AO classification. This is a schema, a comprehensive fracture classification system, which deals with everything from simple wedge compression fractures to horrible fracture dislocations. When focusing specifically on burst fractures, we're talking about essentially injuries of the compressive injuries of the anterior vertebral body with sparing of the posterior tension band. The traditional burst fractures, those with posterior wall involvement, are further divided into incomplete burst fractures, which involve the superior end plate, and complete burst fractures, which involve both the superior and inferior end plate. Obviously, posterior tension band injuries are not burst fractures by definition in the schema, but there is nevertheless a recognition that some fractures, despite not having obvious posterior tension band compromise, nevertheless have a suggestion of some degree of ligamentous injury. And this sort of vagary around these fractures is encompassed by the so-called M1 modifier. This is a descriptive system. It provides a description of fractures, but has been adapted to a more normative prescriptive system, the so-called TL-AOSIS score. This is a modification of the TLEX, which incorporates fracture morphology. Specifically, it assigns a point scale to various fractures, largely based on the morphology, with incomplete burst fractures or A3 injuries receiving 3 points, and complete burst fractures receiving 5 points. Obviously, the M1 modifier plays a role assigning additional points, an additional point if a posterior ligamentous injury is suspected. Fractures with a score of 6 or higher are considered operative. Fractures with a 4 to 6 are considered indeterminate. This is largely remedy an issue with the previous fracture classification, TLEX, which is admirable for its simplicity and utility, but nevertheless leaves a tremendous vagary around burst fractures, which outside of frank ligamentous injury or severe neurologic injury, place most burst fractures into an area of a gray zone, the so-called surgeon's voice, where there's equipoise about whether these fractures are even operative. Despite this, I'd argue even our current fracture classifications fail to fully capture all the salient points when it comes to classifying these fractures. By what do you mean? This is a patient I recently treated, 4-year-old female with an L1 fracture following an MVC, neurologically intact on exam. TLEX score is 2, non-operative. The AO classification, because of the posterior wall involvement, which is classified as an A4, debating how you classify the spinous process fracture, this could be taken as evidence of posterior ligamentous compromise to some degree. So this follows with a TL-AOSIS score somewhere between a 5 and a 6. In terms of operative management, just by way of poll, how many people would try to brace this fracture? Great. I certainly tried to brace this fracture too. I would also argue that this patient has a very morphologically similar fracture. Again, 41-year female, L4 fracture post-MVC, neurologically intact on exam, with a severely comminuted L4 burst fracture. TLIX score, because of the lack of posterior ligamentous compromise or neurologic deficit, classifies as a 2. As a A4 injury without M1 modification or neurologic deficit, this gets a TL-AOSIS score of 5. How many people would try to brace this fracture? Again, same fracture description, very different operative management. And this is not unique to this room or this surgeon. I mean, this has been formally studied. Regarding certain aspects of our most up-to-date classification fracture, even among experts, there's significant disagreement about the M1 status of fractures. And when you compare expert recommendations based on the AOSIS classification, there's a significant disparity between the so-called expert recommendation and the real-world surgery, which performed surgery in about 25% of patients who are recommended for non-operative management. When they looked at factors classified, it comes back to the morphology of the fracture. Although complete and incomplete burst fractures do an admirable job of describing the general fracture landscape, there are a number of features which are not captured in this. Fracture comminution, opposition of fragments, spread of the vertebral body is characterized by intrapedunculaar widening, and laminar fracture, which all capture important aspects of the bone morphology of the fractures, which may not be captured in current classification systems. In terms of actual randomized gold standard evidence evaluating the operative management of neurologically intact burst fractures, not only are the results unclear, they are actually contradictory. There have been 2 major randomized controlled trials. The first by Wood et al. Compared casting to long segment fixation and found that in the long term, not only did non-operative management of these fractures produce equivalent results, actually produced superior results with regard to disability and pain. This stands in contrast to the study of Benga, which looked at short segment management of thoracolumbar A3 burst fractures and found a significant benefit both in terms of pain reduction and return to work. There's a lot of different reasons for these results, both in terms of surgical techniques used, but I think this really highlights that there are certain fractures that we all feel comfortable managing non-operatively, which we nevertheless can't seem to describe. And I think this highlights the first sort of absence in the classification of burst fractures. We really don't have a good language to describe all operative and all non-operative burst fractures. In some ways, it's a situation where you know it when you see it. In terms of the actual surgical management, because we lack this purely, this perfect descriptive, proscriptive language, burst fractures are not playing tic-tac-toe where the fracture morphology completely determines your next move. Instead, I think these have to be addressed with a more nuanced understanding of surgical goals and strategies. What are the goals in management of a burst fracture? In the presence of instability, you have to restore spinal ability and restore alignment. I think there are a variety of strategies for this. Short segment fixation with an index level screw, long segment fixation, or anterior column reconstructing. And in patients with neurologic issues or impending neurologic issues, you also provide decompression of the spine. This can be in the form of laminectomy for patients with relatively mild deficits of the cauda equina, but for more severe deficits, especially those involving the cord, I think transpedicular reduction of fragments or corpectomy should be strongly considered. In terms of deciding between short and long segment fixation, I think a lot of this has to do with the demands you're placing your hardware. For relatively stable fracture morphologies where the bone can share the load, I think short segment fixation with an index screw is reasonable. However, if you are breaking up that bone to get adequate decompression, or if the fracture's already done the work for you and broken up the bone in a significant fashion, I think you really have to talk long segment fixation or anterior column reconstruction. This has actually been formalized in the McCormick classification, which is an old system dating back to the mid-90s, but nevertheless captures some of the important features of whether to proceed with short or long segment fixation. In terms of decompression, I mentioned there are a variety of valid strategies. One that I often hear talked about is ligamentotaxis, the idea that by distracting the fracture, you can stretch the anterior column and realign fragments. This is widely used, but controversial. In my hands, it doesn't work. Whenever I've attempted ligamentotaxis and either obtained a CT or thrown the ultrasound on the canal, I'm often disappointed by the results. Part of the failure may have to be due with my choice of technique. I employ polyaxial screws, and they may not have the same distractive power to reduce the fracture via ligamentotaxis that the monoaxial screws in which the technique was developed. But I also question the validity of this technique in severe fractures. In the severe fractures, severe retropulsion, the kind where you really need that excellent decompression, the PLL can be frequently disrupted. In addition, one goal of burst fracture surgery is to achieve reduction of kyphosis. But distraction, if it's anything, is a kyphosing technique. And I think sort of defeats, at least philosophically, one of the goals of surgery. I bring up the subject of kyphosis because I think it's an underappreciated aspect of burst fractures. Certainly with throwing patients on the table, relying on positioning, you can get a reasonable degree of correction, but I think the location of the fracture and degree of kyphosis is something that's not really adequately captured in current heuristics. By what do I mean by this? This is a patient of mine who presented to my clinic about 10 years after an apparently successful short segment fixation of an L4 burst fracture in Vietnam. She initially had done well, had returned to work, but over the subsequent years developed progressively worsening back pain and, more importantly, severe adjacent segment degeneration at L5S1. Why did this happen? You can see at L4, although she's not frankly kyphotic, she certainly doesn't have that 40 degrees, 30, 40 degrees of lordosis that someone with a flat spine like hers really requires at the L4S1 segment, harkening back to Alexis' talk. I would argue that she's trying to compensate for this by hyperextension at the L5S1 segment, as well as hypolordosing her, or hypokyphosing her thoracic spine, leading to ultimately to early adjacent segment degeneration L5S1. I think, in terms of correction of kyphosis with surgery, I think location of kyphosis matters more, perhaps more lower down the lumbar spine, whereas thoracic kyphosis can be relatively well tolerated by patients. I think even a little bit loss of lordosis in the lower lumbar spine can have long-term effects for patients and should be factored into surgical decision-making. So how do I approach patients? When do I use short segment fixation? It has to be a very narrow subset of patients. They have to have acceptable kyphosis correction when positioned. They have to have good bone stock, both from a fracture perspective. They have to generally be young. And finally, I think they have to be reliable patients. I'm asking a lot from a relatively small construct, both in terms of stiffness and I'm really relying on them not to go back on a jet ski while doing bath salts. If someone happens to bring themselves to the ER for an injury sustained during a high-risk activity, if they're a smoker, I'm more likely to consider long segment fixation. Finally, they really have to have minimal neurologic deficit. If I'm performing a laminectomy and transpeduncular decompression and can't get that index screw to stabilize the short segment fixation, I'm either performing an anterior reconstruction or a long segment fusion. For the vast majority of patients I'm operating on, I still think I am doing long segment fixation. I do this for a couple reasons. Compared to short segment fixations, I think I can get better correction from cantilever bending across the construct. I think, at least in Florida, the majority of patients I'm seeing are older with burst fractures, and they tend to have poorer bone stock. And finally, oftentimes when I'm doing this for patients with neurologic deficits, I'm performing a transpedicular decompression, either unilateral or bilateral. And as such, cannot get that index screw to stabilize a short segment. Obviously, the question I usually get from my residents is, when do you consider corpectomy? There are a couple of scenarios. The first is when I really require robust decompression. For severely comminuted fractures in patients with incomplete neurologic injuries, where I really want to make sure that I've thoroughly decompressed that patient so I can go home and sleep, know I've given the best shot of recovery, I will consider using a corpectomy. For the lower lumbar spine, where restoration of lordosis is so important, I will consider corpectomy to ensure that I can get adequate compression without sacrificing motion segments. Again, so in terms of the actual approach for corpectomy, I think, with the, traditionally anterolateral procedures were favored, and certainly that was how I began my practice. However, as I progressed, lateral procedures have complications, particularly at L4-5, where you can't really go for that quick 20-minute discectomy. A corpectomy in my hands takes time, and I worry about femoral nerve injury. So my approach to these fractures more recently has been to perform a posterior stabilization with screws and posterior decompression, and then try to sneak an expandable cage in there. And I think with the expandable cage technologies, there's usually enough working room between the nerve roots that you can get a posterior cage or robust size there, provide an adequate anterior column restoration while sparing motion segments and correcting lordosis. In terms of adjuncts, cement augmentation, as I mentioned previously, I favor long segment fixation in patients with poor bone stock, which, for better or worse, being in America's retirement community, is encountered more frequently than not. I have very little experience with this in the traumatic setting, but I use it quite frequently for my patients with tumors and a limited life expectancy with good results and low failure rates. Ultrasound is probably the number one surgical adjunct I use for the management of burst fractures with anterior compression. I'll do a peduncular decompression, resect bone fragments, and feel good about myself, only be humbled when I throw the ultrasound and find that there is still a spike of bone or a fragment of disc that I somehow missed. Monoaxial screws, I mentioned previously, my success in getting reductions and getting ligamentotaxis from short segment fixations has been very disappointing. I think at least part of that is the screw system. When you distract or try to manipulate a fracture using monoaxial screws, frequently you're just moving the screw head. And I think this is one area where navigation robotics really has a real advantage. Monoaxial screws are challenging to use. Your alignment has to be perfect. There's very little wiggle room. I think this is an area where further research could be done. So in conclusions, I apologize if I got a little disorganized. I was trying to rush through. But burst fractures are not one fracture, but many, with no one-size-fits-all approach. I think, the TLX 4, the M, the TL AOSIS 4 to 5 level still represents an area where, as a field, we could do better with descriptive techniques. And I think as we develop a better language, kind of a better prescriptive approach to these varied fractures. All right. Thank you very much.
So at USF, are you teaching any classifications then? Is TLX, which is a severity scale, the classification you recommend, or can we maybe advance the field with machine learning in the next generation of CT analysis?
If we've learned one thing from machine learning, it's that, the old approach to artificial intelligence, so this is kind of jumping topics, was to try to develop a series of expert schema, decision pathways, and just by making these complex enough, it was hoped that we could develop, an expert system. That approach has been abandoned in forms of kind of modern artificial intelligence techniques where you just see enough fractures and develop a series of heuristics. That's essentially what the machines are doing. ChatGPT-2 is just developing heuristics based on experience. And I think, how to say this correctly, I think, a more senior surgeon, and this is something I learned, you learn by mistakes, by trying things that haven't worked. I think, having the guidance of senior surgeons is actually very helpful, and being able to reach out to them with, with questions. I think that's the advantage of being in an academic department where I can rely on my colleagues for, advice and tips. I don't think a machine learning algorithm will replace, though, clinical experience and clinical judgment. I mean, at the end of the day, I think, for fractures with neurologic deficit, we take them to the OR. I think for fractures without neurologic deficit, I think it's, reasonable to try to stand them up and walk them. And I think, further differentiation within the fracture field, whether pincer fractures with posterior wall involvement, complete burst fractures. I think a better description of bone combination could help with a teaching residence, but I don't think any classification will ultimately be able to capture the variety of these fractures. Maybe I'm wrong, but.
And then the second question I have is, I think it's a good answer as much as we're in a transition right now. The second thing is, for me, percutaneous screws. The dinosaur
Yes.
is speaking up again. For me, this is one of the most common sources of failure I see. Perhaps not indicated surgeries, stable, marginally kyphotic fracture, neurologically intact, was sent out. The Canadians said we don't need a brace, so it's become dogma, but patients hurt. Then they get percutaneous screws put in, and there's screw migration right through the end plates almost immediately in even osteodense patients. So talk about percutaneous screws, the role of that when you want ideally a stable fusion with the operative and non-operative literature both agreeing that that upper disc end plate that's been burst should fuse one way or the other. How does that play into a role? Does that actually help patients? Does that diminish morbidity? Does that actually lead to healing?
This sort of gets back to a point I tried to make earlier, and maybe I rushed through it, but these are not, all these various techniques are just tools to achieve an end. I think in a sick patient where you need to stabilize them to allow for nursing care, I think percutaneous screws can be extremely useful. I think in an extremely young patient where you plan on removing the screws 4 months later, I think perc screws could be an excellent internal brace. I think for a patient with poor bone stock, I think a patient who, will not reliably show up in clinic until the screws are, haloed out and poking out of his back, I think perc screws may not be the appropriate answer.
Rod Vincent?
No, sir, as a great talk, I enjoy it very much. As an old dinosaur in the room who doesn't practice anymore for 1 week, you say the ligamentotaxis doesn't work, but there was an old system back in the days of with the shank screws and the C-ring you would put, and you had to use a sequence of lordosis and distraction on both sides. You would get, with this system, you were getting a very good ligamentotaxis.
Yeah.
And the literature back in that, you have to look back for 15, 20 years ago, was consistent with good reduction, but I've only seen it work with this system, which is the, well, we're not supposed to say name anyway, it's a system that uses shank screws and C-rings and so.
Yeah. No, I mean, I'm fully willing to concede that ligamentotaxis certainly doesn't work in my hands, or to be frank, some of my partners' hands, but it very well may be that we are using polyaxial screws to do something which they're never designed for.
These were just, obviously, these were just shank screws.
Yeah.
There were shank screws that you would almost bring bicortical, and you have to make them like a bridge fixation, like in a V-shaped fashion. And then you would put C-rings on the rod.
Yes.
And then you would just, with the shanks, you would just do manipulating lordosis. And once it was done, you would go and distract on the C-rings to get them. And you are getting beautiful ligamentotaxis. At least 75% of posterior wall was sucked back there in the vertebral body.
Yeah, I mean, like I said, one of my senior partners who retired last year also swore by the sham system. It's something I was never seen in training. I don't think I could acquire it, if I wanted to.
It's well described, but I'm not sure it still exists anymore. You may have to find it.
And I think, that's why I think there is a compelling reason for trying monoaxial screws in trauma situation, both from a motion-sparing segment standpoint, and maybe it's the secret sauce to make ligamentotaxis work. Dr. Chapman, obviously, you perhaps have maybe some experience with shank screws.
Love them. Absolutely love the fracture module. This is still one of the visionary things. By the way, you could do this percutaneously also if you wanted to. The main learning points that we had, and we actually tested that in the labs, published somewhere, in higher grade burst fractures beyond 30% canal compromise, the PLL is mandatorily torn. So the reduction is not from the PLL. The reduction comes from the discovertebral ligaments, which are the toughest ligaments in the longitudinal spine. And what Vincent said is correct. You can lordose the spine beautifully with monoaxial screws very efficiently, very, very rapidly. Traction is minimally recommendable because the spine will want to collapse again. That's where the implant failures came through. So lordosis, a limited laminectomy, and a ventral disimpaction are very powerful tools. I'm not sure about the transpedicular bone grafting. I have myself, as you probably remember, changed my practice. I do unilateral short pedicle screws on the side where we may do a corpectomy. Dr. Oskuyan is amazing in doing cages, and on the contralateral side, I'll do a long screw trying to raft up the end plate. So short segment fixation is strongly my preference, certainly in the caudal segments, and not over-relying on traction alone. I think that's a completely misguided concept for burst fractures.
Thank you.
Great.
All right, very good.
Great job, Eric.